Okay. Stacy, what do you think? Should we get going since we only have an hour?
Sure, let's do that. We have a lot of fun information to cover. Okay, so welcome everyone to our QMetrics webinar. We're here today to talk about the DMHC's proposed regulation related to timely access to care, which is in the middle of the regulatory process. So there's various audience members on the call today. I think the majority are from health plans, and should be very familiar with the timely access reg. We do have some provider organization members and other members on the phone too. So some of this might be new to you. So I'm going to pass it over to Kelly to kind of give a little introduction to QMetrics and to the what we do and the purpose of today's webinar. Take it away,
Okay.
Kelly.
Thanks, Stacy. Hi, everyone. My name is Kelly Huffman. I'm on the QMetrics leadership team and just wanted to welcome you today. Thanks for joining and taking your lunch break, your virtual lunch break, to spend some time with us and learn about timely access. And just so you know, Stacy had the privilege of reading over 600 pages and gleaning the latest and greatest for all of you folks. So thanks to Stacy, and we hope that you find today's webinar helpful. Just a few housekeeping items for your audio. If you could please keep on mute during the webinar. We do have a chat box where you can enter questions, and I'll be facilitating those. So any questions, feel free to just put them in the chat box, and then we'll do some pauses throughout the webinar for questions. And don't be shy. So we want to answer your questions today. And then if you do have any questions afterwards, you can always email Stacy or myself, and we can get you the answers that you need. So don't worry about that. And we're also recording today, and we will provide the recording as well as the PowerPoint afterwards, so you'll have access to that as well. And Stacy, if you want to just hit the next slide. And folks are still joining. Welcome to those as you're joining. So a little bit about Stacy. If you haven't worked with Stacy before, she has decades of experience in the healthcare industry and regulatory. She worked at Sharp for over 10 years, which is actually where she met Suzanne Dolan, who's the CEO of our organization. And Stacy's worked as a liaison for the DMHC, for CMS, for Covered California. So extensive experience. If you have worked with Stacy, you know that she's really down to earth and easy to work with, and extremely and extremely knowledgeable, which is most important, right? Which is why we're here today. So again, Stacy read pages and pages, hundreds of pages, to just get all the key information for you guys. And then about Suzanne, she couldn't be here today, so I'm kind of filling in. Suzanne is our founder and CEO, and if you have not worked with Suzanne, which we know several of you have, you know that she's all about relationship building and just supporting clients with information and industry knowledge. And she started the organization 15 years ago, and actually this month is our 15th anniversary, so happy birthday, QMetrics. And if you haven't worked with Jim, her husband, the two of them run the organization, and Suzanne has really handpicked and assembled a team based on all of our industry experience. Several of us come from health plan leadership roles, or we worked in different areas in quality improvement, regulatory, as you know, with Stacy. And actually, Stacy and Suzanne, you guys worked together, right, for years and years, and then she recruited Stacy to come and head up as Chief Compliance Officer and head up the regulatory compliance side. So, you know, we continue to grow as an organization, and everyone has different and diverse experience, which was also really important to Suzanne and Jim, not to just have the same kind of area of expertise, but we have such an extensive work experience that we collectively can literally solve all your problems and your needs. So it's a really fun team to be a part of. And on the next, you know, some of you have probably only interacted with us from either maybe the pause survey or on the regulatory compliance side, or maybe quality improvement. But we actually do a lot more, and that has grown significantly in the past couple of years, just based on the team members and our experience that we have. So, we have our Jim, the other side of the house, that leads in advanced analytics and predictive modeling. He was a health economist at a large health plan and was recruited by his wife to work at QMetrics and co-lead the organization. And we do a lot of other things, including encounter data effectiveness, which does impact HEDIS and quality improvement, as you know. We do a lot of different surveys that are regulatory, or they're required in California and other states. And then we also do organizational effectiveness. And our latest service line that we do offer is data aggregator validation, and that is a new program that the NCQA hand-selected QMetrics to partner to build, as well as be the lead auditor or validator for these health information exchanges. And you'll probably, if you haven't kind of heard the buzz around NCQA, that's a new area where it's really exciting because it impacts HEDIS measures directly, so that HIEs can get their data audited, and they can share them with health plans as standard supplemental. So for you on the health plan side, that will impact you in the future. And that's a really new and exciting program. So definitely check out our services on our website and learn more about them. We can skip this, Stacey. Okay, and with that, I'm going to pass it to Stacey. And again, if you've just joined, welcome to our webinar. We're really excited to have you on. There's some familiar faces and names, and there's some new ones, so welcome everybody. We do want this to be interactive, so please do insert your questions in the chat feature in WebEx, or if you have a burning question and we didn't see it, just go ahead and take yourself off mute and ask. This is informal, but it's also informative, so we will be providing the recording afterwards, as well as the PowerPoint. There's a lot of dense information that Stacey's going to get through, but she was really thoughtful about pulling out of that 600 plus page document what was helpful for all of you folks. So with that, Stacey, I'll pass it to you.
Thank you so much, Kelly. So hi everyone, for familiar faces and those who I haven't worked with yet. One other thing that would be helpful to me is if you could enter in the chat box whether you are even, some might be very familiar and have weeded through all of the regulation line by line, maybe through CAP work groups, and you're very familiar. Some may just know that it's out there and just haven't, have looked at it quickly, or, looked at it a little bit. And some may not even know that this proposed regulation is out there. So if we could get an idea just in the chat box to let us know kind of where you are on that spectrum, so that also, during this webinar, I can tailor the information towards you. And then also as a follow-up, as Kelly mentioned, there's a lot of information. And so this presentation is pretty dense, but I wanted to put it together for you as a resource document to take away, and you could kind of look at it on your own and could ask questions later. So I don't want to go into every single nuance because there's a lot. So basically, here's the agenda, just kind of giving a background and overview of why we're here, what the regulation's comprised of, and significant proposed changes, and then the timelines. So again, why are we here? So the Department of Managed Healthcare, as many of you know, have released a proposed amended timely access regulation. It was first issued in June, and then it's been amended, and so we have the December version. So it's been evolving. Since there's so much information out there, I thought it would be a good time for us to discuss like what is in this proposed regulation, just because each version is so long. It includes a lot of not just the reg, but all the methodology and templates, and just kind of parse through that information together so that you feel like you have a good understanding. And if when it gets amended, again, you might want to submit additional comments. So here's, I'm not going to go through every single line here, but here's the overall background and again, purpose of the regulation. So in 2010 is when the initial timely access regulation became effective. And just for those who may not know, it's the timely access regulation sets forth time-elapsed standards, among many other things, but to be able to get in to see your provider, for example, to go if you want to go see your PCP, you should be able to get an appointment within 10 business days of that request. In addition, the regulation sets forth an annual network filing requirement so that the department can assess your network for network adequacy, your providers, to make sure you're meeting the standards in the law. And then part of the it also requires the provider appointment availability survey, among many other things, each year. So I've kind of set forth the journey that we all have been on for the past over 10 years. So basically, in the why we're here today is because in 2014, the legislature granted the department to issue methodologies, templates, tools, guidance without having to do rulemaking. So they were exempt from the APA. And that exemption expires this year. So therefore, this is their deadline for the department to issue their rules to incorporate all those documents and make the changes that they see fit. I've also included all the iterations that's happened on the journeys with changing the pause methodology and requiring an external validator. So you can, if you didn't have the pleasure of living through those days, you could just kind of read through that there. Again, as I mentioned, the initial proposed regulation was issued in June. There was a comment period. The revised text of the proposed regulation was issued in December, and the comment period for that deadline was in the end of January. I reached out to the DMHC to find out to get a feel for what the next steps are. And they did confirm that they are working on amending the proposed regulation and having a third comment period. So that's why it's good, again, for us to be talking. So you feel like you have a good idea of what the current version looks like. And so you could easily pinpoint what they change in the third iteration here. And they say they anticipate submitting the final package to the OAL in second quarter of 2021. And then once the OAL receives it, they have 30 business days to approve or disapprove. And as I mentioned earlier, kind of this is just the breakdown of when you open up that PDF of the regulatory package, this is how it's structured. So you'll see the regulation itself, the first one is 26 pages, and then we have the new rule, which is 2 pages, which is just for measurement year 2021. And then we've got a big bulk here, which are actually just the PDF versions, not just, but the PDF versions of the reporting templates, all of the tabs on the Excel spreadsheets without the instructions. And then we've got the timely access and annual network submission instruction manual, which has now been combined into one document. So it has the instructions and all of that that's listed there. That's almost 200 pages. And then we have the provider appointment availability survey manual, which replaces the current pause methodology document and includes a survey tool. And just generally, so a general overview of what's happening with this regulation. As I mentioned before, the purpose was to just consolidate all of the various different guidance documents that the department has been issuing over the years, the latest versions, put them all together in a consolidated package, and then make sure they're streamlined across the board, and make amendments that provide further specificity. That's the general rule there. So, for example, the general structure still follows the MY 2019 basic methodology with, you could do extraction or 3-step protocol, the timelines for the surveys, faxing and calls, whatnot, those are the same. External validation vendor requirements are the same. The templates are generally the same, but later in this presentation, I'll be calling out what does differ. And again, like I said, they really wanted to make things a lot clearer, define key terms. The goal is to have a standardized process so that the department can more easily compare information across plans and by the year. So I'm just going to pause for one moment because I went over kind of a lot of things quickly. Does anyone have a question or something that came by in the chat, Kelly, that you'd like me to address now?
Well, we didn't have any questions in the chat, but do just want to remind folks that we do want your questions live as you have them. But Stacy also said, you know, you might just need to kind of marinate and take this in and then have them afterwards. So don't be shy on this call, and then we'll also have an opportunity to follow up afterwards with questions as well. Thanks, Stacy. You're doing awesome.
Okay, thanks. And then just if you could take a look to see if people are familiar or not familiar with this content too in the chat, that would be really helpful. So thank you. Okay, so the next two slides, you know, I'm going to be talking about these in more detail in the subsequent slides, but these are kind of the main elements that I pulled out as some significant proposed changes that will be in effect for measurement year 2022. So again, I'll talk about them in detail a little bit further, but first one is the department has created a specific definition for patterns of non-compliance with a percentage threshold and also factors to consider. That is new and kind of a big deal. They've made changes to the enrollee experience survey and the provider SAT survey. The enrollee experience survey changes are more of going to be more of a heavy lift to if it stays as in the current version. Another big change in the proposed regulation is under the provider survey type for the pause fielding. They expanded the specialty provider types to be surveyed to 10 specialty provider survey types. As historically, it's only been 3, so that's a big deal. And then they've shifted some of the dates around. Kind of the network snapshot date when you pull your provider data is going to be January 15th rather than December 31st. And for the pause fielding dates, will be starting in June rather than April, which plans kind of take a little bit of time sometimes to get their data together. But they have plans will have less time to field the survey. And then the filing date has been pushed back to May 1st rather than March 31st. So that's a good thing. Okay, so and then also the department has made some changes about how to file information when plan-to-plan agreements are involved. They also set forth a structure for plans to request alternative access standards to the time-elapsed standards, which is, there hasn't really been a process for that. We've had that on the, time and distance standards for provider access, but so this is new. It's also is going to require specialized plans to complete the network access profile portion. They don't need to field the survey, but this is new for them to complete that portion of the filing. And then the department has created a lot more detail about how they will be determining compliance and non-compliance by plans with the requirements of the regs.
Hey, Stacy, we're getting some replies about the range of knowledge. Thanks for those that aren't shy or just to really to give us a pulse on how we can better tailor the webinar. But it looks like a lot of folks are 4, but we have some 1s, so some brand new, which is really good for us to know. And then some mid-range 3s, haven't looked at it in a while, so this is a good refresher kind of feeling.
Okay, good. That's really helpful. Okay, so great. So I'm just going to go through, the more nitty gritty kind of the things that I pulled out as some of the proposed changes, and these are specific to the regulatory language, not the manual yet. We'll go through that later. So basically, the regulation already included certain definitions, but this proposed regulation has added these additional regulations that were not in the law before, that are listed here. For the most part, these definitions were captured in FAQs or methodologies or template instructions. So now they've been incorporated into the law. So I pulled out here in the next few rows some of the noteworthy definitions. So network capture date, as I mentioned before, they've changed that to January 15th for timely access, because it's a retrospective review. It's January 15th of the prior year. For the ANR, it's January 15th of the reporting year. And so they made that change because the contracts are usually in flux at the end of the year, and so they wanted to have accurate network data. So then we have a definition of network provider. Again, this was already kind of a definition of methodology, FAQs, but it's you'll see this is a trend that they're adding a lot more specificity to the definitions, so that it's really clear to make sure that all plans are populating the templates and fielding the surveys to the proper types of providers. They want to make sure that it's being fielded only to the providers that are truly available to enrollees in the network. I'm not going to
Stacey.
Yes.
It's all right. We have a question, if you don't mind.
Sure.
So the question is regarding COVID. So with the impacts in 2020, do you expect that the health plans and the DMHC will view the survey a little bit differently, just to really kind of be in tune with the COVID impacts?
For measurement year, which measurement year?
They're probably meaning this current measurement year, but because of 2020.
Oh, okay. Right. So that is, I think that might be addressed in one of the FAQs for this measurement year. And I can address that, offline. The purpose of this webinar is to talk about the proposed changes for the future year. But I'll definitely address that after this webinar, with you directly, to whoever asked that.
Yeah, that'd be great.
Typically what the department says is that plans need to include information about this in their narrative in the filing. They really don't typically say that you get a pass. They ask you to include information in your narrative filing about how like the fires or other issues may have an impact on your plan. But I'll definitely circle back with whoever asked that and share my answer with the team. So this is another new proposed kind of a big change, is specifically defining patterns of noncompliance. Historically, the department has left this to the plan to have their own definition and file that. Here, the department set forth a straight 70%. Fewer than 70% of network providers, all provider types combined, had an appointment type within the time elapsed standards, measured for urgent and non-urgent separately. So that's kind of a hard standard that wasn't there before. And then also there are several factors that the department has set forth for the department to consider whether certain instances may rise to a pattern of noncompliance, and I have the elements that would review here. But again, historically, it's been plans had to have a pattern of noncompliance or an instance of noncompliance with significant harm. So these two, this second factor is a new element. We're setting forth how they would determine how specific instances, not necessarily with significant harm, could rise to a pattern of noncompliance. Here, as I mentioned before, there's some changes about how plan-to-plan contract information is filed. So it was really important to the plan to have good clear definitions of who's the primary plan, subcontractor plan, and establishing that the primary plan is to be the reporting plan for the data. And I'll talk a little bit later about how how that process works, how to link that up logistically. Here is another a big proposed change that I think a lot of plans have pushed back on. So this is with the enrollee experience survey, where I just saw someone ask about the pattern of noncompliance. Here is the definition of how the department plans to determine if a pattern of noncompliance exists. And again, you'll be getting this slide. We only have an hour today, so we'll be sending you the slide and deck and the recording, and we're happy to answer, have follow-up questions or whatnot if we're, do get to the end of the time. But you'll have this as a resource. So historically, the enrollee experience survey plans have satisfied this element by using the regular CAPS survey, 2 questions from the CAPS survey that's already fielded by the plan for quality assurance purposes. So plans didn't have to do anything extra to meet this requirement. Well, the department has updated the requirements for the enrollee experience survey and is requiring information, a notice element about language assistance services, and then is requiring the survey to also evaluate members' experience with accessing interpreter services. And additionally, it's requiring the survey to be proactively translated into the enrollee's preferred language if one of the 15 designated languages. So this would be a big change, and it's definitely a comment that I know CAP has submitted. It also made a point that the survey needs to be statistically valid and a reliable methodology, so that they could compare across plans. The provider satisfaction survey also made changes to say it needs to be statistically reliable. It added elements to the survey about assessing language assistance. These 3 bullets here were already captured on the PAWS language assistance addendum in the PAWS methodology to be added in the provider SAT survey. So it's been added here for further clarity, because it wasn't very clear that these elements should be included in the provider SAT survey, and the department fined plans or not necessarily fined, but dinged plans for this in previous years. And then I mentioned requests for alternative time-elapsed standards. Historically, plans are very familiar with requesting alternative access standards for, meeting the 1530 rule, like the distance to your PCP provider. The law did mention that their plans would already have an ability to have a time-elapse alternative request, but there was no structure around it about how that should be done. So the department created a structure for this, but this is good that it allows plans to request an alternative access to the compliance threshold or the time-elapse standards. Quarterly network review. So again, this is something plans were already required to do a quarterly review as part of your kind of quality assurance committee that reports up to the board, among other things, but to include accessibility, availability, and continuity of care. So this amendment adds additional elements that has to be factored into that quarterly review. It maintains those three, but it also specifically requires a quarterly review of network capacity, timely access, and adequacy, and then assessing your advanced access providers. And then speaking of advanced access programs, the current law was silent as to how often plans were required to verify whether their providers that they've designated as advanced access actually meet the standards. So the department the proposed regulation specifies once every 3 years, and they did that to align with the, that's a standard re-credentialing cycle, so that you could kind of fold that in there. And it adds a provision where plans who are designated as advanced access providers are specifically will be required, or plans will need to require those providers to notify them within 30 days when they no longer provide those type of appointments. So you'll need to have a tracking system for that. Okay, determining compliance and non-compliance. I don't know why my screen is showing this. I don't want this. Okay. Sorry, everyone.
We can't see anything, so
oh, good. Okay, I was having this like random box like appearing in my screen. So okay. All right. So the department has specific definitions about what factors it will use to determine whether a plan is non-compliant. It kind of made a big deal in its initial statement of reasons document, which accompanied the first iteration of the regulation, that it's very important to them that plans submit their annual reports timely and accurate and complete, and they QA the report. And so they're, do have a focus on that. And that will be a factor in determining whether a plan is compliant or non-compliant. They definitely do allow plans to implement a corrective action prior to enforcement. And then it sets forth the types of findings where enforcement could be taken. And then this is the last line item for the regulatory change. And I just want to point out again, this is an hour-long presentation. There are definitely other nuances in the proposed regulation that would make changes to current processes. So these are kind of the main ones that I pulled out as being noteworthy. But there are other elements. So the last one is it's the new regulation, which is only effective for 2021, and it sets forth what the department's what it expects from plans for measurement year 2021. At the end, later in this presentation, I'll go through the timeline, have the implementation timeline, because timely access is retrospective. There has to be kind of a ramp up. So basically for measurement year 2021, the department expects you to have certain policies in place, but you'd be fielding the same surveys as within the same structure as we have for measurement year 2019, unless they issue guidance saying they want some other change, but that's the state as it is now. Again, I'm going to pause real quick to see if there have been any comments or if anyone wanted to unmute and ask a question.
No questions in the chat at this time, but like Stacy said, don't be shy. You can unmute and ask, and this is your webinar meeting.
Yeah, and if I'm going useful. Too faster. Okay, so the next section, so I went over the regulation. So this is kind of the some of the significant proposed changes in the timely access and annual network submission instruction manual. Again, they've now combined the two. There used to be two separate ones, so it's all combined into one now. So again, definitions, added new definitions like before. A lot of these definitions were already out there, and they've in the methodology or the instruction tab of templates. But so they've either just added those definitions in, or also added more detail to those definitions for clarity purposes. So these are some of the new, some of the definitions. So accepting new patients, several of the next ones that we're going to be talking about are fields that are on the annual network report filing forms. So these are already fields that are required, but the definitions were kind of short and they were just in the instruction tab. So this is a lot more detailed about who, to give plans more information about who the department expects should be, for you to check the box if they are accepting new patients. So I'm not going to read all of the elements, but they set forth the elements that the plan should assess. Again, these are all already existing fields on the network forms, but they've added further definition about what a network tier is. It's basically the tier where you're having the same cost share level. And then they added a definition for tertiary services. That's a lot more detailed than what's currently in the template forms. They again added more detail for what qualifies as unscheduled urgent services. So again, this is a field on the annual network reporting form to asking whether the provider is available for these type of services. So it creates the elements and the criteria that the plan should evaluate to determine whether you say yes or no. So it's a lot more specific. The grievance definition, so this has to do with the grievance report form that you file as your annual filing to disclose grievances related to access to care. So the complaint categories are I checked, compared side to side. They're all the same categories, but they've consolidated some of them. But one of the big changes is they got rid of the other option. So I know CAP submitted a comment on that because we'd like to keep that in there. And then oversight on plan-to-plan contracts. Departments will now be plans will be required in their filing to submit the filing number of their the procedures that they have in place for oversight of subcontracted plans and delegated entities. So that is a new requirement that was not in the manual before. And this is also a new requirement. So this has to do with prior instances or patterns of noncompliance not previously submitted. So the departments are saying that now they expect plans when they submit their annual filing to proactively look back in previous years to see if there were any patterns or instances that were identified but was not previously filed with the department in the prior year's filing, and to submit that information. And then kind of a description of the corrective action. So, with this, you'll have to have some sort of tracking system. As I mentioned before, the plan-to-plan contract, the department is kind of flip-flop from year to year, well, not flip-flop, refined or kind of updated from year to year, how plans should file information when a plan-to-plan contract is involved. So currently, when so there's one process if the primary plan surveys all the subcontract plan providers. That's clean, that's easy, because the contracted plan isn't required to submit the filing themselves. But if it's with a plan that's required to submit the filing and the subcontracted plan surveys their own providers, instead of referencing those templates in the plan portal, the primary plan will need to actually upload those separate contact lists and raw data forms into their own portal. And then this is a change. They will need to incorporate that data into their one results report form. So that is a change. So they'll, we need to work out the kinks but talk through how that will be done if it stays in the proposed regulation that way. So here's another big change that jumped out to me. So all in all, the provider survey types are the same, with the primary care, specialty care, non-physician mental health, and ancillary and psychiatry. But for the specialty care, they add, historically it's only been these 3 types that are non-bolded that have been have received the survey. So now the department is saying that it expects the plan to include all of these additional bolded provider types in the PAUSE survey. Also, the department added some definition, like specifically stating that pediatric providers should be included. They were kind of inherently included during the previous years, but they weren't called out specifically. So again, adding these provider types who have never had this survey before will definitely require provider education and also increase the amount of surveys that are going to be going out, especially if you are doing a census approach. So more to come with that. So now next up, I'm on the PAUSE manual. So this is pretty basic. Deduplication rule for FQHCs, they just removed the NPI as a factor, which is not really a big change. They created a process for a centralized survey administration when many plans use one organization to do the survey, and that organization applies the survey results across all of the plans. We at QMetrics, we do your own survey as your own survey. We don't, mix data for plans. So, but it does outline what the process is for that. It was outlined in the FAQs previously. For the section where plans should engage in provider outreach prior to fielding the survey, that has always been optional, and it still is optional, but the change here is that if the plans do this, the outreach needs to include required information. Previously, they just suggested information that should be included. And then non-responding provider timeframe, this is a good change here. In the methodology, it currently says if you're unable to initiate a phone call, currently it says within 10 business days from the fax, then you have to mark that as a non-responder. So this is a change which is good. It extends it to 15 days, so it gives you extra time, and you don't have to mark them as a non-responder. On page 20, the advanced access providers, this is providing clarity that plans may not use the provider appointment availability survey itself as a tool to initially determine which of its providers are advanced access providers and mark those providers as compliant on the tool. It says that they have to have their own independent process to do that, but then in 2 years they will be able to use the PAUSE data, but they have to have their own process initially. And then just a little specificity here that the outgoing survey times, they have specific times. It was general before. Let's see. The elements on this slide actually are capturing what was already in an FAQ about urgent care, if there's if the time expires on a weekend or a holiday, how to handle that. And then also the methodology changed. The current methodology, even though the law is based on a business day time frame, that you need to get a PCP appointment within 10 business days, the methodology currently converts that to a calendar day time frame. And this new proposed methodology goes back to using the business day time frame. So I think that's more clear. And then also for the results data template, the department is specifically requiring plans to review the information on that template to identify if the plan identifies any patterns of noncompliance and submit a narrative about that in their timely access report. These are just a little change in the electronic survey script. There was in the initial kind of survey, there was a question that asked, whether a provider provided certain types of appointments, and that was an issue if it wasn't written the exact way. The provider could have just marked that as, no, I don't do that, and the survey could have been marked as ineligible when they really were eligible for the survey. So this is a good change. We're getting rid of that language. And then here they're added this element, which will also be helpful for compliance rates, is asking if an appointment wait time depends on whether an appointment is in person or via telehealth, use a shorter time. So that's good too, especially with these the new age that we're in with the explosion of telehealth. So I think that'll help increase scores. And then here are just a few changes from the pause templates that I noted. I didn't include the network filing templates on this presentation, but basically, so adding information about plan to plan data, adding information as to whether the provider is in the provider directory. They removed the element as to whether the provider is a telehealth provider, because now pretty much every provider is. These two elements are will be newly required information indicating which wave the call is in, and then including the date the survey is initiated. That has not been previously included on this template, and so validators the DMHC haven't really been able to determine whether the survey was fielded with the proper timelines and how to assess waves necessarily. This will provide more detail for that. So before I go to the timeframes, any questions or comments? I know it's a lot of my voice all at once, so thank you.
We don't have any questions in the chat, but we did just remind folks that if you want to ask them, go ahead and unmute yourself and jump in. Stacy's happy to take live questions. And then, of course, as you kind of read this, then you can watch the recording or send this to your teams afterwards. There might be questions, and we'll be giving you an opportunity to have some questions afterwards. And Stacy, I was just thinking that the telehealth piece impacts kind of the question about COVID, and like you said, the explosion of telehealth is really something that we're seeing as a result of COVID. So it looks like the DMHC is already kind of thinking about things from that perspective as well.
Yes, definitely. That's a good point. Okay, so the next few slides, again, like I mentioned, there's a lot of moving parts, and you're like, okay, when do I have to do all this, and when does this take place? And so first of all, it's a proposed regulation right now. It's not active, but you don't want to get caught by surprise when the OAL approves it and it becomes effective, and you have to submit your policies in 3 months, and you weren't aware of this. So again, because the timely access appointment availability survey is fielded, looks back at the previous year, so there's going to be some overlap here. Again, you'll have this as a resource, a deck to look at in more detail. But basically this year, right now, everyone's working hard to get your data together for your filing for measurement year 2020, which is due on March 31st. So that's what you're all busily working on now. And then, so we're going to still stay with the timeline to field the pause survey and the enrollee and provider survey using the current requirements for measurement year 2021. You'll be fielding those as regular, April through December 31st. Again, with a caveat, the department could issue an all-plan letter that changes some of this. So this is what we know as of now. And then you'll have to have your, your policies updated to meet the requirements of that that new regulation. It's very short. It's like 2 pages about compliance for measurement year 2021. And then 3 months after the regulation is effective from the OAL, then the department is expecting an amendment filing. I know CAP is pushing back on that 3-month timeline, so that might be extended, but that's what it is as of now. So for calendar year 2022, we'll just go over to May. May is when the filing you'll submit the timely access filing for measurement year 2021, where you use the business as usual, the current methodology, but you're going to submit that in May. For the annual network review report, you're going to use the new network capture date of January 15th, 2022 for that filing. And then for pause, you will be fielding, for the annual network review, you'll be using the new capture date and the new templates and processes for the annual network report. And then in June to December is when you will field the timely access survey for measurement year 2022 using the new templates and requirements. And then 2023, things should all be aligned going forward. So as I mentioned a few times, I knew many of you, but not all, are members of California Association of Health Plans. I think they've been having an ongoing work group where you've been getting into the nitty-gritty, so some of this might be all news to you. But I know that they have submitted hundreds of very, very detailed comments to the DMHC on behalf of its partner plans on the regulation, instruction manual, the pause manual, and the templates. So if you are a member of CAP and you haven't seen those comments, or you haven't really had a chance to look through them in detail, I suggest getting those from CAP. And then just the next slide, I just pulled out the 4 elements that CAP included in its comment letter with a second comment period. I know we only have 5 or 6 minutes left, so I'm going to continue on. You can read that yourself. So again, reminder, they're going to be amending the regulation. You'll have a chance to submit new comments, and they're expecting to submit the final piece by the second quarter this year. This is a link here to the page where you could get all the regulation documents. And then for us, we have some upcoming QMetrics activities. So I'll obviously be tracking this and providing updates in my regulatory compliance newsletter. In March, CAP will be having a timely access webinar, and QMetrics will be there as one of the sponsors. So we'll be talking about this more in March. We don't have a date for that yet. And then in April, QMetrics will be hosting a virtual pause summit. And this is more not just to talk about the proposed regulation, it's more an overview discussion about kind of where we are looking at best practices. How can plans improve response rates and compliance rates? Strategies to improve provider engagement, what's worked, what's not worked in the past. So it's more about the overall process for timely access in general. So more information will be coming about that. And Kelly, I don't know if you wanted to add anything about this.
Yeah, just we'll follow up. Thank you for everybody for spending an hour with us and joining. Thank you to Stacy for all of that really helpful information. As Stacy said, we only had an hour, so she didn't get into all the nuances and all the deep dives. If you do have a question, you will have an opportunity to send questions in. And then Stacy's also available for just a free chat with you, just to kind of go through things and touch base. We just want to make sure that you're supported and you feel like you have the information you need. So that's really important for us to know that we're setting you up for success. And then, of course, you saw our list of other services and things that you can always engage us with. And Stacy, you mentioned the Pause Summit. April House is one of our new leaders at QMetrics, and she came to really build out our surveys division. And so I don't know if April's wanted to say anything. I don't want to put her on the spot, but we're really excited about the summit, and we're going to have some guest speakers as well. So look for that information, as well as Stacy's new newsletter with lots of interesting news biannually. We just figured out that our current newsletter had so much detail about regulatory compliance that Stacy just needed her own newsletter to get you guys the information you need as soon as it comes out. So thanks again for joining. Stacy, if you wanted to close it out, I think that's it.
No, it's just thank you, everyone. And, I just kind of put myself in your shoes. I know you have so much going on in the day to day, and it's daunting if to weed through that. Even if you have weeded through it yourself, you might have had some questions to see if you're on the same page. So I just want to make it as easy as possible for you. But I really appreciate you taking the time. And as Kelly said, we will be sending out both the slide deck and the recording. And as always, you can reach out whenever.
All right. Well, thanks, everyone. Thanks, Stacy.
Thank you.
Thank you. Thanks.
Thank you.